Okay, it is officially noon. So according to my clock here on my computer here, so I'm going to go ahead and introduce Dr. Will Martinez. It's such a pleasure to introduce one of my favorite colleagues and co-conspirator. So here we go. Whoopsie, there we go. So Dr. Will Martinez is an associate professor, and everyone can hear me, right? Can I get a thumbs up? All good? Okay, thanks, Will. Dr. Will Martinez is an associate professor of psychiatry and behavioral sciences here at the University of California, San Francisco, and he is also the director of child and adolescent services at ZSFG, which is a specialty mental health outpatient program in the Division of Infant, Child, and Adolescent Psychiatry at Zuckerberg San Francisco General Hospital. He is also the director of pediatric mental health for the UCSF Health and Human Rights Initiative and principal investigator of the Fuerte program, a school-based group prevention program targeting newcomer immigrant youth at risk of behavioral health concerns. He is faculty in 2 American Psychological Association accredited internship programs at UCSF/ZSFG, the Multicultural Clinical Training Program, and the Clinical Psychology Training Program. His overall clinical and research aims are concentrating on eliminating behavioral health inequities among minoritized youths with a specific focus on Latinx and immigrant populations. Dr. Martinez takes a socio-ecological approach to understanding these concerns across 3 areas of inquiry. And thank you, Daryl, for that. My audio is a bit muffled. Apologies for that. I will speak, I'll use my New York City voice. The impact of, he's understanding the concerns across 3 areas of inquiry: the impact of social determinants on behavioral health disparities, implementation and dissemination of evidence-based prevention and intervention programming, and policy and advocacy focused on improving conditions for asylee youths. So please join me in welcoming Dr. Will Martinez, one of our very own. Very excited for your talk, Will. And hopefully folks can, this is just my audio issue and not yours. And I will mute myself now. Take it away.
Thanks, Barbara, for the warm introduction. And I'm excited to be here to talk about Fuerte. And kind of want to start by setting the context. You know, I realized the last time I presented at Grand Rounds was on Fuerte, and it was approximately 3, maybe even more, like 3.5 years ago. And it was when we first were awarded the grant, which I'll talk a little bit about in a second, to do an evaluation of Fuerte in San Francisco Unified School District. So I'm excited now to kind of tell you where we're at a couple years later, both the good, the bad, and some of the ugly, aka COVID, and kind of set this up and let you know kind of the challenges we've been experiencing, but some successes as well. I'll also talk a bit about school-based programming generally, especially for newcomers, so you have a good background around that, and then talk more specifically about the last 3 years or so with Fuerte and some of the challenges we face, but some of the lessons that we've learned in the process. I tend to always leave our team slide for last, and I always find myself rushing at the end to do this. So I'm being intentional about starting off with talking about our team and presenting this here. This work would not happen without our wonderful Fuerte team here at UCSF. I'm going to talk about a lot of the work when I mention our Fuerte team. You know, these are our current folks. We have other folks who've been part of our team over the last couple of years from various training programs, pre-doctoral, postdoctoral. We've had medical students involved as well as undergraduate students from UC Berkeley and our wonderful clinical research coordinator. So this work would not be possible without them. So whenever I say Fuerte team, these are the current folks who are part of this. So I want to set the context. You know, for folks who are familiar with immigrant health issues and the inequities that are happening on our southwestern border with Mexico, this is not going to be new information for you. For many others, you know, you've heard a lot about policy advocacy a few years ago. A lot of kind of what's been out there in popular media and what's being discussed has largely gone away as we've turned to COVID, as we've turned to the war in Ukraine, as we've turned to climate change issues and everything else that's happening. Yet what's happening at our southwest border has not ceased, and in many respects has gotten much worse than when this was all in the popular media. So I kind of want to set this frame. This is not only an issue that it continues to be pertinent for the United States and to be frank, for the world, as you know, people are being displaced for various reasons everywhere. And probably at any point in history, this is one of the largest number of folks who've been displaced is right now throughout the world for various reasons. In fiscal year 2019, this is the year before COVID, we've almost half, or over half, I should say, of all folks who were presenting at the border were families with children, and included a significant number of unaccompanied children who were presenting by themselves or under the age of 18 without any caregiver or other family member with them. Those numbers were the highest they've ever been up to that point in 2019. This dropped off during COVID for the obvious reasons, but also with the implementation of a lot of harsh policies at the border, mainly Title 42, which many of you have heard for. And I'm not going to spend too much time talking about the policy issues, but want to put these things out there. There's a number of other protocols that were issued that really resulted in halting kind of how many immigrants and asylees were coming into the United States. You'll see now in 2022, these numbers have dropped significantly in terms of family units and unaccompanied minors. The numbers of individuals are now presenting at the border by themselves are much greater. Adult individuals, I should say, are much greater. And there's a number of reasons why, and there's a lot of speculation about what that is. However, what is pretty much in unison by folks who are involved in this work is that these numbers are gonna, once some of these limitations at the border around policy and immigration policy start to ease, we're gonna see a huge spike in these numbers, because what we do know on the other side in Mexico and in many other Central American countries, there's many children, many unaccompanied minors, many family units that are waiting for the border, to allow for asylees to easily pass through. And folks who know this work, I'm grossly oversimplifying the manner, and that's for lack of time, but just want to put that out there. Specifically, where folks are settling, things have not changed. I'm bringing up a chart from 2014 that was done by the Pew Hispanic Center, looking at unaccompanied minors and where they settle in the United States. Texas, California, Florida have been always the largest receivers of unaccompanied minors. They still are. These are the top 3 states. I have some numbers here by the Bay Area. Los Angeles and California, specifically the metropolitan area, that receives the most unaccompanied minors. The Bay Area following suit right behind, with San Francisco 3rd in terms of counties in the Bay Area. But I should note, the Alameda's number roughly per capita matched San Francisco, as they have about double the population that San Francisco has throughout the county of Alameda. San Mateo's numbers are higher with a smaller population. San Mateo, and there's a few other counties that are getting increased numbers. Marin, Santa Clara, 2 others that really are starting to see an influx for various reasons as well. So this will come up later in some of our expansion of the program. Also, to set the context, where are folks coming from? Mostly, historically, from Mexico has been the largest sender of immigrants who are applying for asylum and other sorts of immigration relief at the border. This started changing in about the early to the late to early 2010s, where we're seeing large numbers of folks coming from Central America, particularly families and unaccompanied children. I always present this figure. I've been presenting it for many years, so folks who've seen other presentations of mine, I always show this. I want to show something different this time around, that for the first time in many years, Mexico, Central Americans are no longer the majority presenting at the border. Now we're seeing the large majority coming from other areas. Not that they're not significant numbers still coming in from that region, but about over 60% right now are coming from the countries of Haiti, Venezuela, Colombia, Peru, and Cuba, who I just realized I didn't put the little arrow there for, but I put the name. These countries, for various reasons, some of them are obvious: Ukraine and the war there. Haiti completely destabilized. I think this morning they announced the last elected officials have officially fled the country, and that country is completely destabilized at the moment, resulting in large numbers of folks. Venezuela for economic and socio-political reasons. Colombia similarly. Lots of these folks are coming in through the Darien Gap, which is the gap between Panama and Colombia, which is an incredibly dangerous journey. And Peru, you know, you may have heard on the news as well, Peru has been having a lot of political destabilization, which is also leading to large migrants. So as you can, you know, surmise, many of these folks are coming in and escaping conditions that put them at high risk for trauma. We're seeing a lot of numbers of children with post-traumatic stress symptoms, but also other concerns like depression, anxiety, and risk-taking behaviors such as substance use. And there's a number of disparities in their access to treatment. Large part of what led to Fuerte is, you know, we were seeing kids who could, if they were identified earlier, could have been in treatment years before, but weren't identified until their symptoms have become more severe, more acute, and then we're finally presenting to outpatient specialty mental health. A lot of these reasons are many of the folks are living in poverty and from low socioeconomic status backgrounds, language barrier issues, not just that many of them speak Spanish, but many of them may speak an indigenous language like Mom. Many folks may be undocumented, and that status also creates some barriers, although in San Francisco County and California in general, that's not an issue for accessing services. Low mental health literacy is important. We'll talk about that in a little bit in more detail. Here for a number of reasons that'll become clearer later with our Fuerte program, but also because a lot of people consider that if these immigrants are residing in areas where there are other immigrants, there's an assumption that they will automatically have a community there, and that's an incorrect assumption many times. And then to give a bit of context for school-based programs, I really like this image I came across. There's students in our schools, particularly in our public schools around the country, especially now with COVID and everything else going on, and the cutbacks and financial issues and political issues in our school districts, it seems like there's a tidal wave coming. But because of this is also makes schools like the most critical point for creating a front line for helping reduce disparities and starting the early identification and development of prevention programs for kids, particularly about behavioral health. Schools allow for facilitation of linkages and initiation with treatment, particularly in schools in San Francisco that have wellness centers, which are essentially like health centers in all of our high schools and in some of our middle schools as well. We know that if there's increased school participation, we see that associated with resilience in terms of mental health issues. And then it also allows for local development at smaller scale when we're thinking about implementation. Each school, it's almost its own fiefdom, its own kind of context. So it allows us to kind of tweak and be flexible with treatment, and also see when they scale up how we think about these treatments. It allows us to test different ideas before scaling out on a larger base. So school-based programs are important. I also want to present this figure just generally about school-based mental health services. The majority of kids who are in mental health treatment, the vast majority receive them in schools. We know that's associated with better economic and social, emotional outcomes. And youth are 6 times more likely to complete mental health treatments in schools than they are in other community settings. So, I do not think I'm overselling by any means how important schools are for our behavioral health system in this country. And then with some colleagues, we're working on a scoping review of school-based programs. And this is also a review we're doing with one of our interns in the multicultural clinical training program, Maria Jimenez Salazar. And we are doing a review, updating some of the past literature on programming specifically for newcomers. And what effectively we're finding that of what we know in the literature, there's potentially, hundreds of other programs that are out there that may not necessarily be reflected in our scientific literature. is that programs can be classified into 3 tiers that largely mirror how schools respond to special education and other types of intervention. The first tier being this overall mental health promotion and support. The vast majority of the literature we have on school-based programming for newcomers focuses in this particular area. A lot of it is around creative arts, drama, therapy, dance, art classes that are geared towards newcomers, not necessarily targeting any specific mental health outcome, but really more of like a general wellness kind of programming that they do for newcomers. This is where the majority kind of overwhelming evidence exists in the literature around programming in schools for newcomers. The second tier, and the one with the least amount of programs, is early intervention prevention. And I'm just going to plug Fuerte right in because that's essentially where we fit in. Least common. We are not aware of any other program like ours, at least in the general area. And to be frank, in California, there's a few other similar programs around the country, but one's focused primarily on prevention with specific mental health outcomes. We are not aware of any, at least as of now. The final tier is tier 3, what we typically think about intervention. So these are specific interventions for kids been identified for need for specialty mental health care. They have a diagnosis, and there's a few programs for that. The most common ones, trauma systems therapy and CBITS, or cognitive behavioral intervention for trauma in the school. So as I mentioned, I've been alluding to this, San Francisco County had a number of needs. There was no evidence of a program that focuses on newcomer immigrant youth, generally, particularly on Latinx, that was on prevention, that was school-based, culturally responsive, trauma-informed, and community engaged. And that is where we came in with Fuerte. Back in 2017, 2018 at this point, we got together with a number of folks across San Francisco Department of Public Health, and the unaccompanied minors work group there, collaborators across different institutions that you will see here, and children's and families through community stakeholder groups to kind of come together and figure out how can we really sustain Fuerte and kind of scale it up and be able to offer it in more schools, train more people, and really roll it out in San Francisco Unified. And we were able to do that. I want to give a big plug to RISE SF. This is Refugee and Immigration Services at San Francisco Unified. They've been our biggest champion in the school district. And whenever I say we need people, champions of school district, that's who they are. I'm usually referring to, and you'll hear how we've been able to do what we do this year, particularly because of them. So I'll talk about that a little bit later, but it's incredibly important to have these champions in the district, and as well as DPH, from the funding. So our collaboration led us to get funded for 5 years through the Mental Health Services Act, through an innovation fund. The Mental Health Services Act, for folks who are not familiar, 1% of all folks who make over $1 million or more, 1% of that goes into the Mental Health Services Act fund, which funds all types of programs focused on prevention, on workforce education and training, capital funding for specialty mental health programs. But there's also a category called innovation. These are programs that have some promising evidence that they may be useful. There's no other sources of funding for it currently in the county, and the state is willing to fund an evaluation of that program with the goal that if we found that the program works as intended, that they'll scale it up throughout the rest of California. So Fuerte fit that program. What we set out to do was conduct an RCT in San Francisco Unified, develop a provider playbook to inform adaptations for other groups needing the program outside of youth from Latin America, and create a framework for collaboration. I'll talk a little bit, I'm going to focus on the RCT. I'll pepper a little bit more about the playbook and the adaptation a little bit later, because COVID has thrown a huge wrench into some of this work, and you'll find out in a bit why. And our primary outcomes with the program, it's focused on prevention again. We are looking to see if we can do early screening and linkage. And we're primarily doing that through using San Francisco County Specialty Mental Health questionnaire, which is the pediatric symptom checklist for children. So we can identify using the same metrics that the county and the state uses for identifying folks for specialty mental health. and then linking to services. We created a measure of mental health literacy. We're looking at how kids understand basic coping skills, how to access mental health services. Do they even understand what mental health is and when to know that they have a concern and need to access services? And then the final outcome, primary outcome, and most importantly, is social connectedness. This is the idea that kids feel connected to others around them, whether it's in school, their neighborhoods, et cetera. Why importantly, this is an outcome that was created by the youth. So we have a community-based participatory model. Much of our stakeholder and early pilot work around this. This is what was identified as the most important outcome for kids. You're going to hear this continues to be the most important outcome. No matter what we do, it always comes up. And we're continue to measure it in a qualitative fashion through our focus group, but we're also measuring it quantitatively, both in objective and subjective ways. Objectively by looking at the number of connections at their neighborhood and school, but then subjectively by asking kids through using a measure of subjective connectedness, how they feel that they're connected to others. Just to give a quick overview of the group, I'm not going to go into too much detail. We have a website. I believe I have it there. If not, it's in one of the other slides you can access and learn more information. But just folks often ask this, like, what's the general modules? We start off by just setting the stage, creating a safe space for kids. We do this in groups of 5 to 8 youth at a time. With a facilitator, the other important thing that I should mention, the facilitators, we always have 2 facilitators, one representing specialty mental health, the other representing the school district. Broadly defined both. We have librarians representing the school because the librarian is the only person in that school who speaks Spanish. They have interest in these issues and we've trained them to deliver the groups as well, along with the specialty mental health provider. Second module, we really try to start building resilience by connecting kids to their culture and also creating group cohesion by them talking with each other about their different cultural backgrounds and being able to share that. Then there's an affect identification followed by affect management kind of modules, very similar CBT, and we base all this on a attachment framework through the attachment resiliency and competency framework. There's a reflection on the journey. This is really where they start to identify the stressors of immigration. We use this immigration stress or culturative stress kind of frameworks to do this and have them talk about their journeys. And then really setting out this communication and attachment and kind of optimistic future outlooks in the last two modules. So year 1 of the RCT. This was COVID, I believe the date we went into shelter in place was March 16th. It was a Monday. Remember, I was on vacation in Guatemala and had to travel back on the day everything shut down on the last flight out of the country before they shut their borders. And we came to this. We spent the first semester, the fall semester, setting everything up to really start this RCT in the spring, had everything ready to go, went to shelter in place, and really just had to scramble and figure this out. And I put this here, A, to highlight, which communities it's impacted, but B, to also highlight, these are the same communities where our schools that we have Fuerte in are located, or are the communities that we're serving are mostly located. And all this is kind of just these confluence of factors that came together to really impact our first year of this RCT. We had to put a pause. We never designed the program to be, evaluated as a telehealth intervention. We had to quickly do that. We also had an adaptation. So if you remember, our second aim with this grant was to adapt this to other groups. We had a postdoc that year, Nufal Rashid, who had everything ready to go to begin the adaptation for our Yemeni and Syrian youth. That's one of our high schools really was pushing and pressuring, I should say, to really develop this because they were having an influx of these youth. And there was much trauma due to the civil wars in both those countries these kids had experienced. And they really were wanting us to develop a program. We had made relationships with a number of community organizations serving these populations throughout the city. I believe, I see Tatiana here. She may even remember the exact dates. It was sometime in April. We had our first community stakeholder meetings. We had mosques. We had different organizations ready to go. And of course, shelter in place happened mid-March. That all got scrambled. Many of those organizations had to pivot to COVID-19 response and outreach. And effectively, we lost that opportunity there. So this is another part that we're still like working to bring back now, is to start bringing our folks together. Another group that is in high need in our county right now are our Chinese immigrants as well. And is another group that we are beginning to kind of develop those relationships, start thinking about these adaptations and getting community input. What we did find of this, though, is that we were able to collect a lot of feasibility data around doing this program over telehealth. We have a great article that we published on this in JCP. I'm not going to talk about this in extreme detail, but we found that this program worked, and it worked in ways, unexpected ways. Again, when we did all the focus groups with our youth, even our facilitators and school personnel we talked to, there was this surprising social connectedness that came out of this. We thought the outcome that would suffer the most from doing this over telehealth would be the social connectedness, because kids just wouldn't have that in-person interaction and meet each other. We found quite the opposite. A lot of these kids found that these groups, they felt isolated. Many of them weren't going to school. They weren't really interacting with kids. This was one of the only venues that they were able to interact with other youth and really build some type of social connectedness. It's great. It's making us think about, how we can think creatively about how to do this in places where it would be tough to do on the ground groups, such as in the Central Valley and other more rural areas of California that have high needs for these groups. But the workforce there may be non-existent. If there are ways to do this over telehealth somehow, and be able to create more capacity there. So feasibility is there. We've been, we're talking about potentially doing this in other ways over telehealth and really trying to pilot some of this out. So we learned a lot there. And I'll get excited about some of these things, and we don't have enough time to talk about all of them in great detail. Second year, this is our first real year of the RCT. I call this our re-entry year. This is re-entry where the schools were back in person. Things were a hot mess, from a better word, the year everywhere, but SFUSD in particular for the purposes of evaluation. The school district was embroiled in political, workforce, and economic crises. There was a lot of turnover. There were layoffs. Many folks here are familiar with the board for SFUSD and all the politics, national stage they went on. These are two newspaper headlines that were, of the newspaper headlines, probably the nicest from others about what was going on in the school district at the time. All of this was the context we were in. We knew this was going to be a tough year, and we decided to scale down and really just focus on two high schools that were the two out of the three of the high schools that had the most number of newcomers. We decided to do that because we knew there was going to be a lot of work to start this back up again and rebuilding of relationships and whatnot, and decided we could do more in just keeping the two schools. Our goal for the year was roughly 100 kids. Here's the consort thing. Without belaboring too much details on this, we were only able to get 42 kids to enroll in the study. I would say this doesn't even speak to the amount of blood, sweat, and tears to an extent that went into getting those 42, with how difficult it was to recruit this year for a number of reasons, which I'll go through in a second. The other issue was data collection. For various reasons, primarily being lack of stakeholders, lack of champions this year, because of turnover. For some were on sabbatical, others were just missing. There's some changes in leadership at the district with the wellness and a few of the other large organizations at the district or departments of the district that we typically collaborate for. We couldn't do data collection in ways that we were prepared to do, and a lot of it had to do over Zoom or after school, which led to immense difficulties in collecting that data. One preliminary, kind of sneak peek into some of this data that we've been gathering. We've actually been gathering information on employment, on these kids, primarily because we were trying to develop the program initially for it to be done after school, because we were having such a hard time figuring out when during the school day we could do this without impacting significantly their academics. We got a lot of pushback from many folks across the district that these kids are not going to show up after school. Many of them are working. And of course, as being the person about it, as the researcher side of me is like, well, let me get that data. Is this actually true? It is not only true, but it is, these kids are working way more hours than any of us thought. Many of them are working more than 20 hours a week, over 90% of them. And we even have kids reporting working full-time, 40 hours a week, a significant chunk of them. So these kids, for economic reasons, many of them are working many hours while also attempting to attend school full-time. So this makes it very difficult to target this group anytime outside of school, making this even more critical that we try to accomplish everything while we're in school during the school day. And as you can see, for our pre-data collection, absolutely poor. 20% is all we were able to get because of that. We improved because we were able to really advocate in the districts and the importance of being able to collect this data so we can properly validate the program. Not only that, but also to help identify these kids, because that lack of data also meant we weren't identifying the kids who were in need either. And we were able to improve that somewhat, but the numbers, were not at the level that we really were expecting. There's something in the chat. Okay, well, great. Thanks, Veronica. So kind of want to talk about some of the barriers that we learned from this year, and this sets up the stage for this year. Low attendance across the district is an issue. We've had there was a number of the major kind of media publications in San Francisco Bay Area have covered this over the last couple of months as their folks are reviewing the data from last year. Chronic absenteeism, as the district defines it, are whenever there's 10% or more days in the school year are missed. The district average is about 30%, but there are a number of high schools where over half of the student body is meeting this chronic absenteeism metric, for the year. Marshall High School is third, and that is one of the high schools where they're actually, I believe Marshall has the second highest number of maybe third in the district, but they also have the third highest in terms of chronic absenteeism. So 60% of their kids are absent 10% or more days of the school year. Think about that. That's a huge number of kids. There are theories on this, the pandemic, obviously, and COVID and the stabilization, the economic reasons with inflation rising and the need for kids to perhaps work more hours. None of these we have great data on, but we're hearing qualitatively and conversations and qualitatively with youth about competing demands. We're talking about competing demands for the groups in school, but now we're talking about competing life demands for school in general, right? And this is a concern that I really want to highlight because, as cost of living increases, I fear this is going to happen more and more with not just our newcomers, but all our low-income youth across the city, and the need to really work and be able to help out their families. High personnel turnover. It's unclear exactly how many were impacted at each school, but many of the programs we work with were. There was layoffs for many school social workers. Politics and culture, we went over that in the media. That created a lot barriers for us because a lot of people were afraid of what they could do because of all this media attention, and really created there was a lot of needing to kind of talk with stakeholders about the program and kind of starting all over again our whole pitch for the program, so to speak. There was a lot of bouncing around as who could give us permission to do different things, even though we have had it because there was changes in leadership. And we were told by folks like, hey, there's a lot going on right now. We just do not have the bandwidth for this. Y'all are just gonna have to figure it out. And part of that was because we didn't have our stakeholders or champions, aka Rise SF, who I shouted out earlier, our principal one. So we held focus groups as we do every year with our participants. We got a good chunk, most of our participants participated in these, and we have some of this data we actually analyzed qualitatively. The theme still came out, even though in this whole issue, and I'm just highlighting this, I could pick so many different quotes, and we've had so many over the years, but the issue of social connectedness, kids, even in this environment, we're still keep bringing up this social connectedness piece. I'll read this quote. Me gustó que no me sentí solo aquí en los Estados Unidos, uno se siente muy solo, pero aquí en el grupo de Fuerte uno no se siente tan solo. And I say it in Spanish, and for folks who don't speak it, I'll say it in English. I like that. I didn't feel loneliness, and in the US, you feel a lot of loneliness. Here in the Fuerte group, you don't feel that loneliness. It comes up, it still creates that space. And, we know from the literature that increased social connectedness associated with, optimal mental health issues. So we'll keep wanting to drive that home. The kids did report barriers we hadn't seen in other years. They're talking about the groups being too short. This is an issue where we were being given time periods that were 30 minutes long to do a group that was designed for at least an hour, optimally for 90 minutes. 30 minutes, for folks who work in schools, they know, how the school day works, how transitions work. That 30 minutes quickly becomes 20. By the time the kids, show up, everyone gets settled. And then, by the time they stop focusing 5 minutes before the next bell rings to go to the next place. So it was giving us not much time. And even the students were reporting they didn't have enough time to spend in these groups. Youth were missing sessions due to other obligations. I mentioned some of them was for work. Some were other obligations from the school that were competing. And we didn't really understand why there were competing obligations, considering we were told this time was free for everybody. It was an issue and never got a great response from school folks on that. And our group facilitators reported poor contact with school officials and little time to do the groups. So this was reported both by the kids as well as the folks who were doing the groups. It was just, there was not much communication there. It was a difficult year, right, for the district. And this is not to lay it on the, district had many challenges. We also had our challenges in terms of our own workforce because we had large turnover in the specialty mental health system during these years, especially around our Spanish-speaking workforce, which meant we had less folks to be able to train in Fuerte who could deliver these groups, which also made that we had less flexibility on our part on which days, times, and groups we can do. So this was just like a perfect storm of things that just created just a huge barriers to being able to do this. And then lessons learned, we need to recruit champions as early as possible in the school year. And when we said early, we, our group knows we started in the summer, just reaching out, everybody know, including myself, texting people like, are you coming back? Please tell me you're coming back this year, because we need your help in helping us kind of champion these things around several areas. We decided, expanding to more schools, maybe this could have been a school site specific. Let's go to other schools. Maybe there'll be less challenges there, and at least it'll give us more flexibility and opportunities. We started recruitment too late. A lot of that was because we were having trouble getting buy-in from the schools until very late. We started much earlier. We hit the ground running in August. As soon as schools open, rather than waiting and really pressured them, and then more time and buy-in from school leadership, which we spent a good bit of time doing. And so we're year 2. This is the year we're in now. Stakeholder return. I put workforce return, and I'll give some, if we have a little bit of time, I'll talk about how many facilitators we trained. We trained a lot more facilitators this year than we've had potentially in any other year of our program. So we've had a lot more workforce that returned to the system that were interested and able to be trained in Fuerte and able to do groups. We expanded into 6 schools. There's potentially 2 more that we're going to do in the spring and add to our RCT. You'll see the numbers went up. You've recruited. We have about 57. It doesn't look like much of a bump, but we're about to, potentially double that in the spring. So this is just across one semester. versus both that were the other numbers. You also see 98% data collection for our pre's. So we went much higher, and a lot of this was because we were able to think of ways to get more time. So our groups are now, we're getting the hour roughly, not all of them exactly, but mostly an hour. Some schools are even giving us a little bit more of that by coupling advisory periods with lunch periods. We've also been able to incorporate our data collection into the groups themselves during that time. So this way there's dedicated time to do that. We're not trying to hunt down the kids in any other times or after school to try to do this. And we've been able to effectively do that. I should also state, let me bring that back too. So 66 of those folks who were eligible, the vast majority are consenting and agreeing to be in the study. I can't understate that, with this hard to reach population, the amount of engagement, how we're getting of the folks we recruit, over 90% are agreeing to be in the study. For school-based samples alone, that's a huge number. For a newcomer immigrant sample alone, that's a huge number. Combine those two, this is a huge number. This is testament to the amount of work our team does on the ground, through our recruitment meetings, how we've kind of spread the word, and in many ways spread the word through their kids' own social networks about the group, by having them talk to other students about it, encouraging the participation, and just really being embedded in the schools and setting the stage kind of for this to increase the participation. So how am I doing on time? Oh, okay, perfect. I'm actually on time. I was telling Barbara, I was very worried I would not make it on time today. Yeah, I was having trouble cutting back, but I'm here. What's going on for the future? So we want to complete this RCT, right? In terms of power, we should get there next year, but we're cutting it close. But that is our intention to show this and complete the RCT. We are currently adapting this for elementary schools. This is not something I thought we would do this, at this stage in the game, but there's just been a kind of confluence and an opportunity here with a partnership with our pediatric colleagues, with Mission Educational Center, which is the primary feeder school for newcomer kids that are in kindergarten through 5th grade, and then a community organization called Good Samaritan. We are starting to pilot what this is going to look like, and they're going to adapt it and start this in the spring, and look at the feasibility of doing this with the younger kids. With that, also is the creation of a caregiver component. For folks who are like, how are you going to do this group? You haven't talked about caregivers. That's always been in the back of our minds. The original iteration of Fuerte, for folks who are familiar with the program and heard me before, the original iteration of this program was done at San Francisco General, at CAS, and it was a family reunification group. So there was family and caregiver. It was the caregivers broadly defined, and the youth were both in groups, and we would do these kind of conjoined group sessions. This was later adapted for the schools to drop the caregiver. We want to bring that back in a way that seems feasible through a school-based program. With elementary schools, that becomes easier because that school has a built-in parent kind of group already as part of their curriculum there. And so we're gonna start talking with the caregivers about what would their participation look like, what kind of material would they be interested in knowing about, and how can we better include them and potentially add this family component to it, and then start to see what that would look like in the older kids. So kind of work backwards from there. Some more feasibility studies. One of our interns from last year, Alejandra Arce, who's postdoc at UCLA now, she added a critical consciousness component to Fuerte. We added some of our focus group collecting qualitative data on how we could add this idea of advocacy and social justice to the program, particularly around immigration-related issues, and what would that look like if we did? And we started collecting a lot of that data. We're actually preparing a manuscript on it to put out there and potentially start piloting, adding that as a potential module for the program as well. Because there's been a lot of great enthusiasm from the schools as well on talking about this, because we really don't touch about on the socio-political aspects of immigration. We really talk about the day-to-day stressors of being in a new country, but not how this is viewed from a socio-political context. The other is the wellness curriculum, and that's just my shorthand for saying, the dream of mine would be that every newcomer in the district would get Fuerte. This would just be part of like a health curriculum. It's an orientation to mental health. It teaches folks these youth how to access mental health services, and whether it's our program or some other similar program, how youth aren't oriented to this, especially when we know this is a population that's a higher risk than others, is beyond me. There is a summer program that is being, its first year of funding, funded through, I believe, Department of Ed. It starts this summer, and there is, we are trying to think about how we can incorporate this as part of their wellness curriculum for the program. So instead of doing this in group form, recruiting kids, we're doing this as a classroom curriculum, and joining in with a teacher to do the curriculum with high school students who are taking these summer classes for credit and thinking about what this would look like as well. So starting to do some of that feasibility studies and then disseminating this out to the Bay Area. As I mentioned, we've been training a lot of folks. We actually were funded through Marin County's Mental Health Services Act to train folks out there, particularly in rural parts of Marin. There's a large need for services for newcomers. There's a lot of migrant families, particularly from Guatemala, that are out in areas of Marin. And there's a large interest in figuring out how to start implementing a lot of this there. We've been training their providers. Alameda, we piloted in Alameda in one of the schools in Oakland, unified as well, this program and rolling it out there. And then we have folks who've been trained outside of California and San Mateo County. Santa Clara, no, we haven't trained Santa Clara people. They're next for our next training. And that is all for me today. Want to make sure that we have time for questions. We have roughly 10 minutes. Want to thank everybody again, thank our team. Here's our website if you want to get more information, and looking forward to kind of having a discussion and answering folks' questions on this.
Thank you so, excuse me, can folks hear me? Great, thank you, Barclay.
I can hear you.
Thank you so much, Dr. Will Martinez, for such an amazing talk. And I'm going to open up. Can you stop sharing, and maybe we could see we'll be able to see each other a little bit better. I do have a question. I'm going to take this opportunity to be really quick. You mentioned the parent component, and I was wondering, in the first phase of the study, including older adolescents, and I was wondering if you could walk us through the consent process for that, and how parents are or not involved around that assenting process, and lessons learned around that, particularly as you move to a phase 2 in establishing a parent component.
Yeah, that's a good question. So we, in the high schools, because we're doing this through wellness, we effectively only have, we were able to get passive consent. So the kids have to consent to the treatment, but the caregivers just get a notice, and if they disagree with the kids' participation, they have to let the school wellness coordinators know. Part of this, we're doing it as essentially services through the wellness programs. The middle schools are a little bit different, depending on every school, I believe, has wellness. So if they're in wellness, same idea, where there's a passive consent, is just a service through wellness that students get. In others, we do need the parental consent and reach out to them. Obviously, in the younger kids, I'll find out. I'm not entirely sure the infrastructure for the elementary schools. I'm getting quickly oriented to this since we've been in the high schools and middle schools. So,
yeah, I just piggybacking. I'm just wondering if that would impact your participation rate. I don't, something to think about, and whether there's some other engagement practices, right, that need to be put in place for the elementary school age kids.
Yeah, and I know that that's something Tatiana and I really wrestled with the IRB, and thankfully the SFUSD's research folks, or what is it, research review board, were understanding of this more than our own, where many of these kids are unaccompanied. There is no caregiver necessarily to sign off. Many of the other kids who are living with relatives, they may not be biological relatives, legal guardians, etc. They may or may not be involved. And then many of our other kids are living independently. They live in a roommate situation. We see it in, even in our outpatient clinic, we see that many times. There's no caregiver. So we wanted to be flexible with that because we didn't want to exclude kids just for that need.
Thank you for that. Feel free to unmute yourself if you have a question.
I'll jump in. Thanks, Will, for this extraordinary work and a really wonderful presentation today. I have a question about your reference to incorporating Fuerte into the classroom curriculum and whether the makeup of the classes is exclusive of newcomers or whether it's a combination of kids that aren't. And how that would impact the experience for everybody.
That is a great question. That is part of the challenges that we're trying to work through exactly that right now for that reason. So in the curriculum, so this is one of the issues. The majority of kids, when they are receiving services, even if it's a newcomer school, they're not being grouped by national, they're mixed classrooms from kids. So even if it's a newcomer school, they're all newcomers, but they're from different regions of the world. They may not speak Spanish or not all speak Spanish necessarily. It becomes a challenge. And it becomes a challenge having to do with equity, right? If we're providing a type of wellness curriculum, we need to then be able to provide a similar curriculum to every kid in that classroom, or else we're creating an us versus them. Without getting unnecessarily too much into the politics of the district or just generally in the schools, part of the pressure to start adapting this early was because that was being felt already in the schools. Like we had this program for our Latin American newcomers, but this other large group of Middle Eastern, North African newcomers, primarily Yemeni and Syrian newcomers, don't have anything. Like, are you gonna provide something? And part of that is like, we can't do it all. But then part of that also is, well, yeah, let me help. That makes sense. And we didn't expect to adapt this. I have a postdoc who's an Arabic speaker and interested in this. This just aligns perfectly. Let's do it. Then COVID decided to do something else about it. So, and that ended. But no, that's incredible challenge right now. It's trying to work through how do we provide a curriculum and not create an us versus them by necessarily removing. How is there another kind of parallel curriculum that could be offered to other groups that may not necessarily speak in Spanish? So thank you for bringing that up. That's the biggest challenge we're having right now on how to implement this in the summer, because those classrooms very similarly they're all newcomers, but they're not all from Latin America. It's going to be a mixed group.
There's a question, I think, in the chat, anonymous. Is there a similar program to yours and other? Oh, Karen, do you want to go ahead and ask your question? Okay, I'll go ahead and step in then. Is there a similar program to yours in other California counties? You said that you have done trainings even in other states. And thanks so much for all your heroic work.
Yeah, that's a good question. I mean, it's the Fuerte program. We train folks on doing Fuerte in other counties, and they're sort of doing, Fuerte light as we try to call it. They don't get the coordination, they don't get the support from us, only because we've been funded to do this in San Francisco, but we were able to train them, and they're doing some version of this in Marin. I believe there's a school in San Rafael. Tatiana, you may remember the details of this. It's been a while for me, and I don't trust my memory these days. I think in San Rafael, there's a high school there, and then somewhere near Inverness, I know it was up near, what's it called? I'm thinking on the national park up there, Point Reyes.
Point Reyes.
Yeah. Because I remember we were debating on doing it in person. I'm like, oh, I'll go up to for a day. And then there was another COVID lockdown. We had to do it over Zoom, and we didn't do that. So there's versions of that. We actually have a school social worker that we train in San Mateo County. I believe she's in Redwood City, if I remember correctly. And she got trained on our program and this other program called Strong, which has nothing to do with us. So for folks who know, Fuerte means strong in English, right? And it's called Strong, and it's a new intervention. It was developed in Canada that's been adapted by folks in Chicago that I first learned about on a panel presenting on Fuerte, and then seeing the next person present on Strong. And that person was an undergraduate student when I was a graduate student in my lab. I oversaw her, and we were like, what? How did we end up here? Well, and she got trained in both, and it's creating like a mini system of care where she runs the newcomers through Fuerte, and then the ones that need more, she then provides this Strong intervention, which is similar to CBITS. They just focus more on like Latin American experience, but it's CBT principles around trauma-focused treatment. So, and then, yeah, go ahead.
Oh, I wanted to highlight Elaine's question, your first question. Do you want to go ahead and ask?
Yeah, so my question was just about when you mentioned that there is a school representative during those sessions, in addition to having a mental health provider. I was wondering, what role do school representatives play during those sessions? Because that really interests me. And also, have you thought of, or your team thought of, involving school social workers or school psychs, so that like there's more of a community engagement piece to it and a community participatory piece to your program?
Yeah, that's a great question, Elaine. So I would say that the vast majority of our school facilitators tend to be CHOWs. These are the what's CHOW stand for, Tatiana? I see you on there. I always forget what it says. Children's Health
Community Health Outreach Worker.
So they're not social workers. They're actually, I think they're BA level folks, and there's more CHOWs than there are social workers. There was when we first started, every school had a social worker, at least one. Some schools even had more than one. We are now at a point where, similar to school psychologists, most of the schools share a social worker. They're like one social worker for every 2 to 3 schools. Most schools tend to have at least one or more CHOWs. So they tend to be who we use. There's also the issue of language. So we have one school I'm thinking of that there is no one in their wellness center who speaks Spanish. They're getting high numbers of newcomers in because of reasons that we didn't predict, but all the newcomer feeder schools are full. They're over-enrolled. This school is under-enrolled, but in this geographic region. So the spillover to the school is happening because they're one of the only schools that are not over-enrolled. So they're getting vast numbers of newcomers now and needed to quickly kind of develop a programming, but they don't have the resources. They had a school librarian who spoke Spanish, who is very involved with the newcomer immigrant groups, and we trained them, and they've been doing a great work. The facilitators are there. We co-facilitate the groups. They're there to help with the general group facilitation, especially the mental health person effectively takes the lead, but they're co-facilitating and they're working together to kind of do the curriculum together. The other important part about the school person is if there's needs within the school, they can make those connections, right? So the specialty mental health person is the bridge to the specialty mental health world, and if those connections and linkages need to be made, the school person, if there's academic or other needs for connection. And each school is a variation on a theme, though. They all function differently, and it's part of the flexibility of the program, but that's generally what the structure is.
We have about a minute. Yeah. Just accolades, Dr. Martinez. We have about, I don't know, maybe 40 seconds left to our time together. Before everyone hops off, it's been such a pleasure to have you again, talking with us about the next stage of your work, and we hope you better come back and present on the next pieces. It's been fantastic to see everyone. your faces and your names, and hope everyone can stay, enjoy this little bit of respite from the rain. And thank you, Dr. Martinez, so very much. And Tatiana, thank you. And Nicole and Manon, and everyone else on the Fuerte team for such amazing work and collaboration. Take good care, everyone.